I have one question, sir, to all the Sreekumar sir was mentioning about structural and functional difference in that. I have heard almost all the doctors saying to patients who come for treatment for any degenerative condition, saying that this is a structural damage has already been happened and it is irreversible, but still we'll give some medicine, some change also. Have you noticed any structural change happening positively? Reversing the condition, any of you, if you have?
Is it to all of you?
Any experience from all the three physicians?
I would answer that there are these two aspects there. One, structural change is there for 2 or 3 different tissues. For example, the bone undergoing a change, the disc undergoing a change. One change, if there is a herniated disc, it's a structural change which is reversible. The herniated disc can always come back. Whereas if we are talking about an osteochondrosis, that I don't think will get reversed spontaneously. That structural change will not get reversed. What is happening in a nerve injury? Because of the pressure, there is a local demyelination that is taking place in the nerve. That gets reversed because the cells are capable of remyelinating themselves given the right atmosphere. And according to me, that is what really our treatment is doing. When a patient is complaining of cervical neck pain, he is invariably talking about muscular pain, which is only functional. There is nothing structural there, other than forming a spasm. So when we are giving a small, either an external therapy or an internal medication which is giving us instantaneous result, we are meaning that we are giving a temporary relief to the muscular spasm. And that's the first functional change that we are observing. When there is a relief in the radiculopathy, unless the damage to the nerve is relieved, the radiculopathy, that is the numbness or sensory loss or motor weakness in the arms, they will not get reversed unless the nerve gets into healing. Pain relief is possible without any improvement in the disease. For example, even a person with excruciating pain, if his attention is diverted to something very, very severe, he will totally forget this pain. For example, there is also the condition of, I was mentioning in the differential diagnosis, very often there is a lot of number of patients who come to us with severe back pain. You look at all examinations, you ask him to do an SLR, absolutely negative. You ask him to do an MRI, X-ray, everything is negative, but he complains of severe back pain. Is definitely possible. And that pain is attributed to psychological causes. Depression is one of the major causes of chronic back pain. So there is nothing structural there, but there is a functional aspect to it. And you treat for depression, the back pain will disappear, whereas you keep treating for anything else, it will not go.
It may aggravate.
Pardon me?
It may aggravate.
It may aggravate also because the more money is also being lost in the process. So if you treat him for depression, you can find that the problem is really reversing. So the muscular component is the first one to get reversed. The neurological component is the one which gets reversed in the intermediate phase, which is what we see as a typical relief that people get in radiculopathy, etc., and myelopathy. Whereas if it has reached a stage of more solid tissues, which is happening over a very, very long period of time, like what happens with a stenosis, by hypertrophy of the ligaments, as well as seriously deranged osteochondrosis. From my experience, I have not seen relief. I have seen patients who have stuck on to us for 3 years, 4 years, etc. They get symptomatic relief, but nothing close to cure. If you look at their X-ray, it is still the same. Symptomatic relief is basically relief of muscular spasm and relief of neurological injury. So those two things are happening with treatment, not the bone getting resolved. According to me, if somebody has got something to show that it is getting resolved, it's going to be one more additional point for me. I have not seen that happening.
See, again, I want to stress one important point. My views in the perspective of a traumatology may be somewhat different. See, what exactly happens after an injury? For example, take the case of IVDP. Immediately following IVDP, if you take an X-ray, if you take an MRI, there will be gross prolapse, gross thickening of the ligamentum flavum, and there will be what I call, it's not the other type of thickening of ligamentum flavum. It may be due to the pressure effects, which is caused by bleeding. of the surrounding tissue. See what happens at that time, severe pain will be there, and thereafter that MRI is there. That length and breadth and height of the intervertebral disc we have noted. After a period of time, when our treatments are over, say some 14 days or 21 days treatment we have done, whether it is Murivana or whether it is the other type of Panchakarma therapy we have given, after that if you take an MRI, naturally there will be a reduction. And still after 6 months or 1 year, if you take another MRI, the size of the disc will even be smaller. Pathologically smaller, I would say, because the disc will be dehydrated. Initially it may be very larger, thereafter after some 21 days or so, it will be comparatively normal, but after 6 months or 1 year if you take an MRI, it will be still smaller, which means that disc is lost, that disc is dehydrated. Structural changes are there, yes, of course, but it is a kaleidoscopic type of structural changes. One day, next day, like that. Let me draw your attention straight away to cerebrovascular accidents. Cerebrovascular accidents, what happened? Pakshagata. In the first day, they themselves are telling that next day they can take another CT scan or MRI. Because changes will be there, definitely. Day by day changes will be there. The patient is coming to us, we are managing with all sorts of Panchakarma therapies, application, heat application, Sweda, Sneha, etc. After a period of time, the patient can walk. Okay. But then, even thereafter, if you take an MRI or a CT, things would not differ much, except that the perilesional edema would have reduced. It is the perilesional edema which is reduced in that cases, not the original lesion. That I would like to tell. Okay, thank you.
I would just like to add that morning we have heard that there is always a structural change established before the symptoms are expressed, like, and then the next part of it is that whether our intervention can do any change in the or reverse the structural damage. One thing I would like to add is that once we know that this is a condition which goes in for chronicity over long years, the deterioration is getting more and more, degeneration is getting more and more. So our intervention that I will try to explain in my presentation should be aimed at what is the normal deteriorating or degeneration happening and whether our intervention can prevent it also. So that is one aspect which I would like to add. The disc has to get degenerated naturally once the pulposus is out, and it's a natural process. But whether our intervention somehow, we know that the disc is a very area where the circulation is very less, still due to other many factors which can be attributed to whether we can see that the integrity is not lost as it would have been if we do not interfere. That's what I would say. So that conservation is also one of the aspects in our approach.
I have a question. This is, regarding the type of treatment that we have to adopt in, cervical spondylosis from both an outpatient perspective and inpatient. There is some kind of difficulty in deciding which patient will require, inpatient treatment and which can be managed. Most of the patients who come also find it very difficult to, undergo long periods of therapy. And in my own experience, some cases we have found unexpected improvement even at the OPD level. In some cases, it does not happen. And another thing is the duration of treatment that we have to give. How long do we have to follow up these patients? There are cases where, up to 3 years, the patients have had to, continue therapy. So in some cases, we have seen there will be one course of intensive IP treatment in a year, which is followed up again next year. But can some kind of general guidelines or based on your experience, which will bring in little more clarity, if we can develop some kind of algorithms here, it would be helpful for clinicians.
I think that's a very relevant question, because very often we have to set an expectation. In the first consultation itself, we are expected to set an expectation for the patient. They also want to know by when they can expect to see some results. So that's again depending on the chronicity of the disease and the radiological this thing. As doctor was saying, the first attempt is to give them a symptomatic relief. At that point of time, maybe relieving the local pain would be a very first step to promise, and that should take place typically within a week's time, from my experience. But if you are talking about radiculopathy, I have seen that getting better with about 1 month to 2 months time. Generally, it doesn't go beyond 2 months to get rid of radiculopathy, which is not a very chronic origin, unless there is a severe stenosis and all that, and repeated episodes. OP treatment itself, in my opinion, if it is only cervical spondylosis, just OP treatment with some appropriate medication and asking them to do their own oil application, some local mobilization of the neck exercises that they do themselves, is able to give very, very tangible results in more than 90% of the patients. Very often patients come to us with overlaps. Along with cervical spondylosis, they also have a systemic disease which is hampering them. They also have a psychological component. As I said, very often we tend to ignore that. People who are bordering on depression invariably complain of more pain, which is a component we as doctors generally ignore. The mindset of the patient is one of the most important. According to me, 90% of what we are doing in Ayurvedic clinics is to also give them a rest and give them a lot of psychological pep-up, which is treating them for the mind as well. When they come to an IP center and have a full-fledged full body massage and all that, there is a big stress relief that is taking place, which gives them an overall advantage irrespective of the disease that they suffer from. And that is documented not only in Ayurvedic treatment, they are also, if you look at the critical studies on cervical spondylosis, the outcome between people who have undergone surgery and people who have not undergone surgery, after 5 years, they have found that it is more or less the same. And the criticism towards surgery is that after all, the results have come more out of the rest rather than out of the surgery. So rest itself is giving them a huge benefit. So one of the main advantages that we get when we are able to handle them on an IP basis is that we are able to give them much more than just treating cervical spondylosis. Otherwise, just if it is the cervical spondylosis, in my opinion, we don't need inpatient treatment, because it's a long drawn disease. In any case, the degeneration, as he said, the ultimate solution in the treatment of cervical spondylosis is to see that the degeneration doesn't progress further. And that is, I think, a lifelong effort. So that is to go on. There is no point in giving an acute treatment just for say 20 days or so, putting them into a hospital. They have to take care of themselves lifelong if they have to avoid further complications. So to my experience, if it is only cervical spondylosis, I wouldn't really want to have them admitted in the IP.
That happens to be one of the leading conditions treated in patients.
Because patients want symptomatic relief, so very often we give them what they want. Not that essentially, and most of them come with comorbidities, by then they are already fed up. See, typically a person who is having cervical spondylosis has been going on with his cervical spondylosis for a long time. He is dragging himself because he doesn't find time to rest, he doesn't find time to exercise, so he is also waiting for a break. In that scenario, we admit them. Otherwise, from my experience, I don't know whether I have admitted any patient for cervical spondylosis so far. I've treated them only at the OP level and with very good success.
In the angle of a surgeon, I'll tell you that when there is a history of injury, recent history of injury, in a patient who is having cervical spondylosis, such a patient is to be admitted. But such a patient is to be admitted, what for? Just giving proper rest and immobilization, not for our Panchakarma therapies, the other type of therapies. Complete rest, complete immobilization with a package of drugs like Morivana. That itself will solve the problem in majority of the instances. I have witnessed so many cases which the cases have to be just carried inside the hospital, right from the ambulance. But we are not doing any therapy. The patient after some 10 days or 15 days can walk. What therapy have we given? Complete rest itself, which is not possible in an OP environment, and our massages etc. will aggravate the condition only. So the treatment should be done, whether it is IP or OP, after judging the condition of the patient. That's what I am telling. And the very chronic cases also have to be admitted for management. Very chronic, very aged individuals also have to be admitted for management. Because while doing our Panchakarma therapy, even in spur formation, chronic spur formation cases, etc., if the patient is traveling in a rough road, the condition will be aggravated. What's the use of Sneha Sweda? But in an ordinary case of cervical spondylosis, which 80% of the patients are harboring, such IP treatment are not must. I'll reinforce the opinion of Dr. Ramesh.
I think I will come to that when the presentation is there. There is a protocol, examination protocol. I was just telling to Dr. Ramesh that along with that examination of a cervical spondylitic patient, or that would have been one more added, this one for the seminar. In that there is a procedure called SMART. In all procedures in physiotherapy examination, etc. That is actually specific, is for specific, measurable, achievable. I thought that can be transferred to the fixing the treatment also. And R I have forgotten. T is timely. So that is very important. So that segregation of the patient or classification of the patient according to the criteria where they can be handled in the OP, and whether IP treatment as suggested by maybe a initial course of IP treatment after a OP intervention will be useful for schooling them to do the Nidana Parivardhana and other things, as well as trying to let them know what they have and what they don't have in future.
Can I share another point, I think, which none of us has really discussed? One issue again which we encounter very commonly is the question of immobilizing the neck. What sort of immobil? You are covering that? Then we don't have to discuss that. Because very often we prescribe, there is a big confusion whether to wear a cervical collar or not is a big question. I would strongly say that there is no substitute to a cervical collar while traveling. And that is not meant just for a patient with cervical spondylosis. I think every human being has to wear a collar if he has to be traveling in this vertical position. If you are not lying down and traveling, because the cervical disc is not designed to take vertical jerks. We are designed to walk. While you are walking, the jerk is very minimal, it is a slow pace. Whereas especially when we are traveling long distances, we tend to sleep when the muscles are all very loose, and invariably you tend to nod like this. In the process, there is a severe, aggravation of the symptom that happens. Any patient with cervical spondylosis will get an aggravation if he travels and he sleeps while travel. So a cervical collar is a very excellent protection, both in terms of preventing his head from going out of position, as well as in preventing the physical impact of the vertical jerk while he is traveling on a vehicle. I have started advising this to everybody who visits my clinic. I tell them, you better have a collar which you wear only while you travel. That's a very preventive step as well. Another very important thing is, very many times we note in the clinic that the doctor had advised them to wear a collar, and the patient will comment that he has got an aggravation of pain after wearing the collar. It is likely if the size of the collar is not perfectly fixed. Many times that instruction is not given. Patients wear a collar that is larger than their neck. Then they go into hyperextension. Hyperextension will aggravate the pain. So if the collar has to fit snugly into the neck when the patient is looking straight. So you should not have any extension of the neck while the collar is fit. So if an exactly fitting collar is prescribed to the patient, he definitely feels better. Another thing is, the collar should not be used continuously. There are many people who mistake that they have to be wearing the collar 24 hours of the day and 365 days of the year. That is not good, because when you physically support the neck all the time, the muscles of the neck will lose their strength because of disuse, and that itself will aggravate the problem. So wearing the collar while traveling and avoiding the collar and strengthening the neck muscles with exercise would be the ideal protocol, according to me.
So I have just one more question. What about combining of Ayurveda and physiotherapy together?
Yes, I think they have to be seamlessly integrated, because physiotherapy has mastered the art of specifically strengthening each muscle. The same thing, if we know by our own different methods, either through yoga or whatever, ultimately, as doctor was saying, you have to handle the muscles you have to handle the different structural components. I think physiotherapy is very good at specifying exercise protocols to specifically strengthen the muscle. I think all of us have made it a practice to prescribe that they do small neck rotations and then, press the neck like this and, tense the muscles of the neck on all directions. To strengthen the muscles of the neck is very essential. But I don't know to what extent procedures like ultrasonography or tensor, etc. is needed. Even without that, patients are recovering. Maybe with that, they will feel a little better faster. That's all it is. Otherwise, it's not absolutely necessary.
No, I was just asking whether there's any advantage in combining the two. Like, does physiotherapy work better along with Ayurvedic treatment? Or
Yes. I mean, meaning faster. Maybe it can accelerate it a little bit because symptomatic relief is obtained with physiotherapy. If they do an ultrasound or some sort of the stimulation, I don't know exactly which protocol they are using because I think they also switch procedures. Some of them use ultrasound, some of them are using TENS, etc. But that seems to give a temporary relief. Just I have not measured it objectively to say whether that is better than this sort of massage which we are able. I have not been able to do that still.
No, what specific question I was having in mind was, is it better to have physiotherapy after some snehana has
Yes. That certainly in chronic cases, as doctor was mentioning, that is the approach. For us, all exercise is with snehana only. The snehana definitely, see, from my experience, I think what exercise is doing and what snehana is doing is actually the same. And when they are done together, it is an additive effect. Snehana externally is basically giving us additional circulation, peripheral circulation. From my opinion, what is happening even with an abhyangam is that when we apply the oil, we stop radiating heat from the skin because it blocks the pores. And then we are not radiating heat from the skin, so heat builds up in the body. When the heat builds up in the body tries to dissipate the heat by introducing more of peripheral circulation and induces sweating. And when we sweat only, that temperature comes down, and that is supposed to be the ideal endpoint of an abhyangam. We are supposed to apply oil and wait till we start spontaneously sweating, which means we have created a peripheral circulation which is simulating exercise. So actually we are doing, it's a passive form of giving an exercise. Our abhyanga oil application is a passive exercise, and when somebody is doing an active exercise, we accelerate the effect, we multiply the peripheral circulatory effects of abhyangam.
The example is cited in our science itself. In Vadavyati, we are learning that application of sneha is like you can manipulate the body in such Shushkanya Kashtani, Sneha Swedo Vadanad, Shaktam Karmanyadam Nedam, Kimugatrani Jevedam. At the same time, Vagbara himself is telling at the end of Sweda chapter or Vasti chapter, I don't know, that without doing Sneha, if you are involving in Sweda and other Panchakarma therapies, it would be like Daru Shishkamina Iva Anama Shariram Tasya Jiryate. Like that it is mentioned. So indulgence in Sneha before Sweda is must in conditions where Sneha is indicated. This is exactly the role of physiotherapy. When this is exactly the benefit of physiotherapy if you are coupling it with the Ayurvedic modality of treatment. In my hospital, we are for the past 11 years we are using the service of a modern physiotherapist also. Along with our Ayurveda treatment, it gives better results than Ayurveda when used alone.
I think it is better we recognize that what physiotherapy we are actually doing in our procedures. Once we have understood that, then what the modern physiotherapy can contribute to complement it or supplement it, if there is anything. Because in physiotherapy, generally we have a tendency to feel that it is exercise therapy only. Even heat therapy, cold therapy, compression or massage, manipulation. Now manual treatments have actually taken over the scene, not in India but elsewhere. And those methods are almost all similar to our Marma and Kalari massage, Nadi Marma Chikitsa, etc. So now they are into manual therapies, and almost the physiotherapy done with all these gamuts, whether they are basically if it has to be heat, it has to be heat. If it has to be cold, it has to be cold. That has been proved. And if pressure effects are going to make. What all, we are all doing those things only, I believe, that I will call Ayurvedic physiotherapy when we are doing this Kriya Kramas many a times with compounding them with the medicines, whatever suitable for that time. But now, Spandanam, one workshop which was conducted 3 years back, that was an eye-opener, where we can complement or supplement other methods developed in the modern physiotherapy towards this one, and I think that is what the attempt will, what is being done in our Marma clinic in our institution also, that an attempt to see that the patient is better off at the OPD level itself with the involvement of physiotherapist in such conditions.
Sir, Sreekumar sir, what about traction? Traction
Action means?
in your hospital, any traction or anything
Traction is-
along with physical?
Traction should be contraindicated in where there is adhesion, because it does bring about adhesional lysis, but at the cost of severe pain. Severe pain will be there after traction if the patient, if the condition is chronic, I would suggest. If the condition is chronic, you should never do traction. Only after Snehasweda, after some 2 weeks of Snehasweda, you can allow traction to start. Otherwise, there will be complications. But at the same time, if the condition is not that chronic, traction can be applied. What's the benefit of traction? Without Snehasweda, what does happen if traction is done? Naturally, the bones will be distant. There is a chance for disc regeneration. We are giving a chance for the disc to regenerate. But it will not happen if adhesions are there and if the conditions are very chronic.
Yeah, even now modern doctors are also quite divided on the role of traction. Many of them are not really recommending. If the nerve is also impinged, if there is a radiculopathy because of an impinged nerve, it can really produce severe damage to the nerve if you are doing a traction, because it is already held in that bony position. So if the lesion is only disc, if you are sure there is no bone involvement, there is only disc, then some cases traction will give some relief. But it's considered more dangerous than beneficial by most of the senior people now. Because if there is a severe impingement, you are pulling it apart, is going to damage the nerve further.
I will also draw the attention to the Bhagna Chikitsa and Chet Adhichittam. If there is any Adhichittam overriding whatever dislocation, type of dislocation which is happening there, or displacement we can call in spondylosis like conditions, then only there is a reason for putting traction. And this one is also a soft collar or a rigid collar is a sort of stationary traction which is being applied also.
Any more questions from the?
You were mentioning about foot drops. Is it related foot drops related with the cervical myelopathy or what we are
Cervical myelopathy.
How is it? What is the relevance of that? How does it come?
See, foot drop can happen because the nerves which are coming to the leg are also passing through the neck. The spinal cord at that point contains the nerves for the entire body. So at the neck level, if there is a compression on the spinal cord, it can affect the nerves which are supplying the parts of the body below the neck. So in that particular condition, they were possibly pressing on the long tracts which were emerging at the lumbar level and innervating the leg. So when that nerve was compressed very severely there, the patient developed a foot drop. They thought it was a lumbar issue and had a surgery of the lumbar spine. There was a disc which was degenerated in the lumbar area also. Yep. They thought that this is because of that without doing a reflex test also. They didn't know it was an upper motor neuron lesion.
Okay, that is the route what I am asking. How can we differentially diagnose between lumbar and the cervical?
Just reflexes. The reflexes, knee jerk is exaggerated in the case of cervical myelopathy resulting in lower limb deformity, derangements. So we have to routinely look at deep tendon reflexes while looking at patients with lower limb abnormalities especially. Even upper limb we are supposed to see, but you are not going to miss out anything much if you are not looking there. But if there is a lower limb abnormality, we have to look at reflexes without fail, because that can reveal a lot of stories. Sometimes you may detect, a patient with paraplegic tendency could be a neoplasm arising somewhere else, So whether it is upper motor or lower motor is the first thing that we need to ascertain, which is very, very simple. Just learning to do some 3 deep tendon reflexes will do.
Really, I had got a case like that which was being treated also. It was a failed case for me. The presentation was as if it was a coronary paralysis with more of involvement of one side only. I was thinking of the normal procedures only, and they had already visited doctors, specialists, and come. So I thought that everything is ruled out and I can go ahead with our usual Snehasveda. But the patient did not never respond, and then I advised that that was an advocate's mother. So I thought that better play safe. I told that you again go for a neurologist, another neurologist's opinion. And that neurologist could cite a cervical lesion, which was a very, very cervical stenosis with very less space and along with myelopathic involvement. So that's a relevant question as far as the practitioner is concerned. It has to be a neck or cervical pathology has to be ruled out whenever there is a confusing symptom like that.
I have a clinical condition to tell. It was some 20 years ago. One patient had come off, it was not pain actually what the patient was having. The patient was finding it difficult to use his left hand. Patient difficulty, perunilla. In Malayalam he told that kayyu perunilla. It was very difficult to use the arm. Thinking it was a simple case of neurological involvement. At that time, if I remember correctly, I prescribed the same Prasarinyati Kashaya, etc. The patient hadn't visited me even after 3 months. After 3 months, suddenly the patient came into my room and told me that it is very difficult even to lift the hand. So I told him, where were you? I asked the patient. Say, doctor, after taking your medicines for some 2 weeks, I felt okay, but now again I am having the condition, but it is now worsened. The patient cannot even lift the hand. So I did that deep tendon reflex of the elbow, and it was found that it was highly exaggerated. At that point itself, I came to a diagnosis of neoplasia. Neoplasia in the frontal lobe, because exactly I could tell it was in the frontal lobe, because it was in the left arm, it is at the right side. Because it was the hand, it was in the frontal lobe. I suspected, it was some 20 years ago, mind you. CT scan was not available everywhere, but I sent the patient to CT scan, and it was a case of frontal lobe tumor of the size of a tennis ball. But I sent the patient elsewhere. Elsewhere means he was sent to Sri Chitra hospital. It was learned that the patient did surgery, and I was not aware of the patient till some 2 years ago, when the patient came with an invitation for her daughter's marriage. Say, if your diagnosis is correct, this is a very simple tool, the knee hammer. It is a very simple tool which will give you marvelous results of diagnosis. Deep tendon reflexes is the simplest, most economical tool which you have got in order to differentially diagnose upper motor neuron lesions and lower motor neuron lesions. So you should use it.
But I think the basic training in such examinations are also should be part of such CME programs, I think, because most of the doctors, they are either not familiar with the actual examination or
they should learn.
But they should. It's a must. Sir, reorient in that.
I know. 90% of our clinics don't have an examination table, and we hardly, if at all there is one, it is full of books.
That is there.
Not patients lying there. I think that's the first lesson we have to learn. We have to examine patients. We have to learn. I agree that that's the educational scenario which has to improve. So I think there's no substitute to that. We are going to miss out a lot of stuff. My friend Jaydevan used to say that not in the case of cervical, that in the case of hip, he had encountered, 2-3 cases he always used to say in our meetings. I'll just share it for our common forum. He used to say of a patient who was suffering from he was not able to walk, and he was undergoing treatment under various institutions and doctors, great doctor, Ayurvedic doctors have treated him 6-7 years, and he came to Dr. Jayadevan's private OP, and he felt, now what am I going to do which all these people have not done? So he said, first step, he has not taken any investigation so far, and he was advised to take just an X-ray, and it was found out that he had no head of the femur. It was totally gone. Avascular necrosis of the femur with total loss of the head of femur, and we are continuously doing spiritual. One man will say, no, Rutshakriya, we have to do Podikiri and Udvartanam. Another person will say, no, Vasti and Navarakiri. And all sorts of things were going on without fundamentally seeing what the problem is. And finally, it was a avascular necrosis of femur. He had his hip replaced and started walking wonderfully after 7 years of so-called treatment. And another case recently of an osteoarthrosis knee, which was treated again by a lot of different institutions, where finally it was a patient who reported to the college, and from there they finally advised him to have this thing, and it was a particular type of, I think, particular chondroma or synovial tumor, which was producing spongy like balls. Some 850 such balls were removed from the knee. Crostuka Shirshanandu Varanjita Adichi Bulucha treatment and Upanaham, this, that, we were doing everything under the sun without having one X-ray or one MRI done till that date. This is a big mistake we can often make. So I think at least at this level we should learn that, we depend on modern investigation wherever it's available. Certain things, of course, ultimate diagnosis is still clinical. In spite of all other tests available, we must know where to look at. Dr. Mahadevan always used to tell a joke about somebody who prescribed an MRI of the thigh because somebody had a pain in the thigh. So we should not do that, but wherever appropriate, I think we should be able to use modern diagnostic tools. I think we will make fools of ourselves if we don't do that. As the moment they go to the other stream, they will put them through this test and show them precisely what they are suffering from. So we don't have the privilege of guessing anymore. We have to be precise. I think that's the message I would like to share.
And that's mainly for the students who are there in the back seat. And we have in fact started some orientation program under Dr. Sreevaths. It should happen every Saturday. So all of you are welcome for that. One question from Dr. Prasad.
Last, I think 45 days or 2 months, around 2 months back, I had neck stiffness. Generally, we have two practices. One is local management without any knowledge, or we do some massage, whatever it may be. So we encourage it because we feel get relief. We don't practice in our hospital hard massages or maybe setting of the spine massage especially. But whereas my junior was here, he was doing some extraordinary pressurizing massage, or maybe in Andhra we used to go to a barber shop, after a cutting they do a twisting of a head. Is it advisable in setting when you have complications like a hard massage or maybe a bone setting with severe painful inducing techniques? Hope you...
Manipulative massage. Especially in Tamil Nadu, there are many places where people are there and local.
Manipulation will help in dislocation. In dislocated structures, it is a therapeutic strategy which is followed from Ashtanga Hridaya, Vagbhara period onwards to do manipulation. But if in a degenerative case, I am very much skeptical to prescribe a manipulative technique, and there are instances where people have manipulated the spine with devastating neurological complications, the patients have met with devastating neurological complications after manipulation. So it should be done very cautiously. You would be stepping into burning grounds if you are doing unnecessary and illogical manipulation. See, people who are doing manipulations means like people in certain parts of Andhra Pradesh and Mysore, etc. They are not educated. They don't know the structure. For every case of low back ache or every case of cervical pain, they will do manipulate, whoever is taken to them. They don't know anything about structures. So it is, I think it is illogical to do manipulation in where it is not warranted.
Yeah, I think there is a lot. In the West, we have this osteopaths who basically treat all these diseases through manipulation. Chiropractors and the osteopaths, both of them practice this thing. And I know of one person who has learnt Kalari under 3 schools here. He has also clubbed it with osteopathy. He is a fantastic person who knows manipulation to such an extent. He is so scientific about it. He says our Kalari, what they are doing, they themselves don't know. Because they have lost it in the tradition. Originally, the Kalari method of massage was so much scientific, so closely resembling osteopathy, and what these chiropractors are doing. He has studied under 3 teachers of Kalari, 3 schools of Kalari here. He has sort of mastered what they are doing and combined it with what these people are doing. And he has got a beautiful chart to explain what they are trying to do. So he's got a vertebral column with him. That is what all these chiropractors do. So they show you what exactly is wrong with your spine, and they manipulate it very beautifully, totally different from what we generally do. He also does podikiri, etc. Totally different from the way we do podikiri. We are doing it more as a local, a circulatory or anti-inflammatory sort of intervention. He does it as a pressure technique. He gives it, he uses the podikiri to create some local heat, and then it is done with so much of pressure. He presses that kiri on the spot with that sort of pressure, as if he is using that to manipulate the vertebrae. Because he is a person who knows the anatomy and is doing it with a lot of that skill. But the same thing done by somebody, as he said, doesn't have knowledge of the structure, can be very, very, very damaging.
Sir, during your presentation, you had an explanation about cervical spondylosis along with carpal tunnel syndrome. So, could you say what kind of treatment can be done for this condition? Because they don't respond for the regular treatments we do. So,
first thing is to diagnose that it is a carpal tunnel syndrome. Very often that itself we are likely to miss it off. The cardinal test to distinguish carpal tunnel syndrome is electrical conduction studies. If you do an index finger stimulation test, the latency period for the current to reach the electrode is measured in that, and if that is specifically delayed and there is no, between this and this brachial area they measure the electrical conductivity, and if that alone is less, immediately the diagnosis is of carpal tunnel syndrome. Once that is diagnosed, one tries to find out why carpal tunnel syndrome. Whether it is genetical in nature, whether it is due to diabetes, whether it is due to hypertrophy of anything, whether it is due to rheumatoid nodules in the carpal tunnel. So there are so many causes of why carpal tunnel syndrome can manifest. So next is to getting into that diagnosis. To me, I think treatment is not at all a problem. Everyone knows treatment. What we don't know is diagnosis. So if we diagnose the condition perfectly, we all know if it is a rheumatic nodule, we have to treat the rheumatology. If it's a structurally, genetically narrow carpal tunnel, the only way would be surgery. If it is a hypertrophy of the nerve due to certain things like different diseases, then you have to treat that particular cause. So treatment to me is the simplest step in the whole process, and diagnosis is the crux of success or failure.
Thank you, sir.
Good afternoon, sir. Just a small opinion from the panel. Nowadays, when we get patients, most of them come with all the investigations done, and there is specific pathology which we can assess. But most of the doctors who come here, who are basically from Kerala and from our AVP branches, the normal traditional kashayams, the arishtams, the lehyams and the oil, everything is given in a methodical way. How far, most of them know all the kashayams. They give Dhanvantram kashayam, they give Maharasnadi kashayam, they give Ashtavargam kashayam. So what I would like to know is, after seeing a detailed MRI report, and if there is a disc bulge, if there is a stenosis, or if there is a nerve compression, does the type of kashayam which you prescribe, undergo any change, or it's only the symptomatic pathology you see and you decide the medications? Or for different specific, if there's an MRI report shows that there is a specific stenosis, do you think that a specific kashayam has to be given? Or if there is a specific nerve root compression, is there a change in kashayams or a treatment protocol depending on the MRI report as such?
For one, I have a different background altogether. I don't try to treat cervical spondylosis with kashayam at all. Because, as I said, since I am practicing fundamentally in Tamil Nadu, and most of the patients, I hardly get patient who comes to my clinic as the day one he gets a pain. He's invariably gone to a number of other people. They come to us as chronic patients, and I start them straight on Snigdha Prayoga because they are already past the AMA stage or anything, and I'm not a surgical person. They know that I don't handle acute emergencies. They don't come to me for acute conditions. They may get an aggravation of pain on an acute manner, but the disease is chronic. I used to prescribe a number of kashayams earlier. Along with kashayams, I used to give snehas. I've been trying to see what is the common denominator. I've been trying to eliminate this variation that we are trying to do. I've been looking at it very critically. I'm just sharing my personal thing. I don't say that that's the way we have to do it, but what I've been trying to do is I was also using a whole range of different products for different conditions. But I was always feeling many of the times it's a theoretical perception that we have about a particular product and a big variation that we pursue in the condition. I was trying to see what is going to happen if you're going to do the same thing again. I was trying some tests myself, and I found out there's a common denominator. There are few things which are commonly working, and then it really doesn't matter. Many other things, we cannot really measure what is happening out of this drug or what is happening out of this. We are doing a big set of procedures and we are getting a result, and we assume that this result is because of this X, Y or Z. We are doing X, Y, Z, A, B, C all together. Very difficult for us to find out which one is doing what. Unless we do single procedures over extended periods of time, we are not able to establish. Even then, I'm sure the researchers who are here will agree that to establish a cause and effect is one of the most difficult things to do. To precisely say that this is what produced this and not something else. We will have an experience of saying that I did this and the patient got cured. But whether he got cured because of this or even in spite of this, we don't know. Isn't it? Because we don't have the procedure of having a control in our clinical level. We cannot have one patient for whom, identical patient for whom we give this procedure and another patient for whom we don't give this procedure. And if we are able to track like this X number of cases, only then we can say that if there is a similar pattern, that everyone who has been given this procedure has responded this way, and everyone who has not had this procedure has not responded this way, then you can say this procedure is responsible for this relief. I think this is what is lacking in Ayurveda. We have evidences of having administered a number of things and evidence of people having responded. But we don't have evidence of people who have not undergone the treatment and we don't know how they are. So very often that is where when we make a claim in any forum other than in our own forums, if you go to an allopathic forum and make a claim that we have got a treatment which is very effective, and I look at the statistics that is submitted, the majority of the diseases for which we are claiming excellent relief are published in literature as spontaneously getting cured. If you look at back pain, I think bread, butter, jam of our practice and survival is back pain, isn't it? All Ayurvedic centers we are surviving predominantly on low back pain. And low back pain is one of the conditions that is supposed to be 90% curable through self-limiting condition. And automatically it limits itself after some period of time. So we really don't know precisely what is happening with what intervention is the feeling I have ultimately. But there are certain, when we try to bring it down the parameters, we now know that, as he was saying, if you have to use an anti-inflammatory and you are using an anti-degenerative, it will not fit. But whether you are using X anti-inflammatory or X plus 1 or X plus 2, you are within the range, you are likely to be right. If you are totally off the range, you are likely to have a problem, which is why each doctor has his own route of success to describe. Now if we call all of us sitting in this room, I am sure everyone has treated cervical spondylosis successfully. And if you try to see what they have used, it will be a totally heterogeneous list of products, which means all of those are working, if what we are doing is working. All these are working. And if it is not working, then all that we are doing is not working. I find it extremely difficult. So what I have been trying to do is to eliminate lot of the variations that we are trying to do and to find what is the least common denominator which is working. And in that effort, I have done that very, very seriously for cervical spondylosis. And from my perspective, that one product which I mentioned about has been doing the job for me. I used to prescribe 1 or 2 kashayams, 1 or 2 tablets, and then maybe Rashimula Haridegi also at times, and then also Sneham, and also external application, everything. Now I have reduced it to just the Sneham internally and just oil application externally. With this, majority of the patients are getting relieved. This is my personal observation. I don't say that this is a fully validated final result, but this is an experiment that I have been going through, and where I have found success. I have stopped prescribing too many things for this. I'm trying to come out with one common denominator. Of course, I don't say it is very individualized treatment, but ultimately when we say we are treating cervical spondylosis, we are into Vyadhi Viparita Chikitsa. If you are saying I am treating this person, then it's a full analysis, and then you are not treating cervical spondylosis, you are treating that person. Then I don't say that one product will fit him. But if you say, is there a treatment for cervical spondylosis, I can say yes, there is a product which will work in cervical spondylosis.
Irrespective of the finding in the MRI, as Keshavan asked, whether it is.
Anyway, that is answered the question. I think we all generally treat the patient. And so the gamut of this one is required, so much of medicines is required. One thing is true that what Dr. Keshavan meant is that whether there is any change in prescription based on the investigatory findings, advanced investigatory findings. No, actually there is not. Two things are, it is done. One is that now we are getting patients as tertiary patients or secondary patients after investigation, so we are looking into it. And one thing, as had been explained for the previous question, we can avoid meddling with things which we cannot meddle with unwantedly. So that is useful in that way. And how far it is going to determine our prescriptions or treatment depends on, again, the first thing which we discussed. Okay, we have this lesion, we have understood that it may be due to that. So whether any reversible changes can be done or any static effect can be continued in that if the investigation is repeated later. So that is the only thing. Otherwise, we will not be able to answer even the modern doctors how they treated the cervical spondylosis or any other condition, IVDP conditions 10 years or 15 years back. Because MRI was not a norm there. As Sir told, it was CT was just in many places. So still people were getting treated, people were getting cured. So now one attention which I think Dr. Ramesh told is that whether we have to put up a question ourselves, that whether we are classifying the patients properly, whether we are over prescribing things with just notions, that's what we have to, if we have to become more scientific.
Dr. Ramesh, I have a question for you. It sounds totally contradictory, your two statements. You said towards the end, the latter part of the conversation, that when 2 or 3 drugs are used, the synergism may be there, and you cannot, the synergism of the drugs may be there, and you cannot attribute it to the effect of one particular drug. At the same time, you yourself told in the beginning that your Savilon was working wonders when tried alone. How would you like to explain it once again, please?
I didn't get your second part. What did you say?
No, initially you said Savilon, your product, when given alone, was enough in treating cervical spondylosis. But in the latter part, you said, when Dr. Keshavan put it, that several medicines when used, you cannot claim the effect of one particular medicine curing cervical spondylosis. It could be used synergism, and it cannot be attributed to the effect of one particular drug. At the same time, initially you said that Savilon alone was enough in curing the. Would you please explain it?
Yes.